study, but don't use them. I think in half a year. I forget usually.
Half a year.
Half a
Good
year
job,
would be
man.
like
3 days
quite
is
good.
not bad already.
Okay, let's start. One more time. I remind everyone today is recorded. So let's try to be constructive. Okay, so today we'll talk about epidemiological study design. Welcome everyone. This is a series of lectures on epidemiology for analysts. Okay, so learning objectives. Yeah, so let's give me a minute. I need to swap the thing again. I think you all can see lah. I think it's fine lah. Oh, here. Oh, yeah. Doesn't matter. Okay, so yeah, to define the different types of study design, there's a difference between observational and experimental study. Very simply, observation means you don't intervene. Okay, experimental studies, you may intervene. Okay, so there's some experimental ways you can do it. Sometimes the intervention is deliberate. That's a randomized control trial, for example. Sometimes it's just quasi-experimental. So it's just by chance you have two groups that are different and you just observe them. Yeah, but they have different interventions. So later we'll discuss more about that. So we talk about cohort, case control, cross-sectional, randomized control trial. Don't worry, we'll cover them one by one. Okay, let's start with the first one. Okay, so you have observational versus experimental design. As mentioned, observational means you observe a cohort. Okay, you don't really do anything to them. Okay, experimental means you may actually intervene. One group you may give an intervention like cholesterol medicine. The other group you don't give. Then you compare the two results. But sometimes you cannot really do experimental because it may be unfair. So you may want to compare groups that were given, let's say, a drug and the other group that was given the drug, but they refused to take it. Then you compare the two groups because it's not ethical not to give the drugs. So this could be a simple experimental design. So for example, COVID, some people refuse to be vaccinated, right? So those who refuse to be vaccinated, you observe their rates of getting hospitalized and mortality due to COVID. And then you compare with the groups that actually went for vaccination because it's not right, at least once the vaccine is proven to be effective, to withhold vaccine. So these are some important facts to remember. Then you have a cohort study. Cohort study is where you follow a group of population, a group of people of certain characteristics. For example, a cohort study of teachers. So you follow the teachers cohort, 5 years, 10 years, 15, 20, 30 years. Okay, later discuss, it's expensive and it's very long. Okay, case control usually is for more rare cases. You find cases of people with, let's say, rare cancer, and then you find a group of controls which is similar to them but doesn't have the cancer, and you compare the characteristics between the two of them. And then you have cross-section study, very common. You have one cross-section, but the probability is that the temporality is not established because you do not know which came first. Did the smokers get lung cancer or did the lung cancer become smokers? So you can't really show which came first. So this is cross-section study. And then I mentioned the experimental studies. So there are randomized control trial, and there's also quasi, where it's not fully experimental, but we try our best. Something called natural experiment. Another term is called natural experiment. Okay, before I continue, any questions? If not, I'll move on to the next slide. I think this is one a good slide to compare. So there are two types: observational, experimental, interventional. Okay. Okay, so observational, you can have population or individual based. We're not going to cover everything today. So for population based, it can be a descriptive study for the population. It can be analytical study. Okay, for example, you can look at a population of Singaporeans, for example, Singapore population, look at the sugar intake, look at obesity, and you see a trend. This analytical. So it's ecological because looking at the population. The person who eat more sugar may not get diabetes, but you're looking at the population. So you're just saying that a group of population with a high intake of sugar, and then they may have higher rates of diabetes. But do note that the individual will be the other way around. Those who are taking more sugar may not have diabetes. Yeah. So that's why it's called population based. You're not looking at individual data. Okay, so these are some studies that usually we can do sometimes. This is called population based study. Then you have individual based. You're talking about individual. The one who take more sugar, does he get diabetes or not? So that's an individual basis. Then doctors, they like to do this thing called case report. Case report is one rare case, one case that write up. That is called a case report. Okay, one. A case series is 3. So 3 cases, you can make into a case report. Sorry, 3 reports you can make into a case series. Okay, so doctors usually very busy, so they only focus on case report for one case. You look at all the studies, and then you have more than 1, 3, then you can call it a case series. Okay, that's called descriptive study.
Seems to be these are the era whereby data is less available, and then we talk about all this one.
We still do that for rare cases. For example, a rare case of rare reports lah. So you do have rare reports. Yeah. But you're right lah. Right now, the standard of journals have risen. If you submit case report, case series may not be published because it's not very useful lah. Okay, so the standard has gone up. So now we talk more about analytics. So we talk about cross-section study or prevalence study. For example, prevalence of diabetes. So you get a group of population, you test them whether they got diabetes or not, and then you can say how many percent got diabetes, how many don't have. So that's called prevalence study. It's cross-sectional. Okay. Then you have a case control study. So I mentioned these are usually for rare diseases. So you have rare cases and they match the controls. And a cohort study or follow-up study, you have a group of population, you follow them up. Okay, so this is the observation studies. This is usually what we do here in our department. We do a lot of observation study. Some of our colleagues in the evaluation group, they do intervention study. Okay. However, it's very difficult to get randomized control trial. Why? Why is it difficult? Huh? Ethics is one thing. What else? Any other things other than ethics? You're done experiment, right? Well, what's the problem with doing randomized control trial?
Need a very large sample
You need double the number because let's say you get 100 patients, right? Then you tell this 100 patient, we're going to randomize you half to one thing, half to another thing. So end up only 50 people. So for 100 people that you recruited very painstakingly, okay, then only half you have the treatment, the other half don't treatment. So you have to recruit more than the one you need, at least double, so that you have 100 patients on the intervention, 100 patients on the intervention. Next thing is also patient may not be keen. Some people want the intervention. So if you tell them you can be randomized, you can be a placebo group, you can be an intervention group. Some people don't want. They want guarantee treatment because sometimes they think treatment is better than nothing. So that's why we have some difficulty having a randomized control trial. So for RCT, the sample size calculation is very, very important because it's expensive. Okay? Because it's expensive, you need to make sure that the amount that you recruited is enough to show the efficacy. So that's why they have very strict numbers for randomized control trial, usually about 100, 200. This is a rough number for each arm. Then you have this thing called the quasi-experimental, okay, which is not really randomized because sometimes it's difficult to randomize. So you have different types of design. For example, you got what's that? Wedge design. Is it wedge design or is it step design? So you recruit a one class, and then after that you recruit another classroom and another classroom. So each one becomes control previously. So because you can't do the invention all at the same time, so you do it in steps. Okay. I'm not sure what's the term called. Maybe Joey know. Anyone knows? Maybe Sunshine know what is that called? Step, wedge, or those something. Basically, the idea is that you don't recruit everyone at the same time. So we recruit class A. So class A is the intervention group. The rest are all controls. Then you recruit class B. So now class B is the intervention group. Class A may have stopped the intervention. Then class A can be the control. Or class C, which haven't started, could be a control, and so on. So it's different phases. You have different set of case and control. Okay, so this is in a nutshell what you know. Yes.
So other things are your interrupted time series and all these things. Do you classify them under this?
No, yeah, it's quasi-experimental. Interrupted time series. Maybe you can explain what is interrupted time series?
I think you are the lecturer here.
Okay, so interrupted time series, I think is when there's I'm not sure in what context that, but what I know is that sometimes you have some intervention, some event that cause the thing to not happen, and you compare the groups before and after the event. Is that what you mean? Interrupted time series?
I think sometimes, I mean, we are very scared of a pre-post design whereby there are things, but if there's a snapshot there, there's a certain time, then we can say that, hey, this is and then it becomes very two distinct points. We can consider this as a interrupted time series. That means an event happened at this point in time, 2020, we call COVID, whatever. And then the pattern change. So we can attribute, in a way, the changes due to these things.
Okay, so it's like event. So the event will be the trend may change because of certain
The
event.
other thing that they also talk about is I don't know whether is it considered as may not be interrupted time series, but they talk about like for instance across age, right? Across age. So like maybe across age we should see a kind of continuous increase in ASU or whatever. I remember at some point that they compare like geriatric versus GRM, sorry, geriatric versus GEM-MED, is it for departments? And they attribute that okay, if by right it should be like this continuous change, but because they are happen being kept under GRM, and then they say that oh because they handle only from this age onwards, and then they attribute the differences due to this. Do you remember? I'll throw back the question to you.
Sorry, okay. Maybe I just for the sake of those online. So basically, interrupted time series, it looks at the impact of intervention by comparing a long-term period before and after the intervention. So it says, for example, if this is the trend, okay, and then the event happen or intervention happens, this trend may be altered by the event, but you must look at it at a long term, not a short term. So maybe this is a upward trend. Okay, for example, this is a trend of obesity, and they have a HPB, a health promotion board campaign, and then the trend for obesity drops to a different level. Even though after the event, you can still see an increase, but the rate of increase may have slowed down. Then you attribute this to the effect of the intervention, which is a health promotion board campaign. So this is what I mean by interrupted time series. Sorry, what was the question? I didn't catch the question.
I think I remember vaguely. I mean, they talk about like, for instance, and it's not in terms of time series, but they talk in terms of age. So we know that the elderly will take on a higher utilization or whatever. But in general, we see some kind of continuous kind of changes across the graph. But if there's something that you detect there's a kink, then you can say that oh, there's certain interventions that is done to this age group because it suddenly basically we are talking about so-called non-continuous or what you call non-continuous. There's a jump and they can kind of like you say attribute. I think sometimes it's more of the way that we try to attribute factors when it's a non-RCT. RCT can attribute factors, right? That's the purpose of RCTs.
So I guess what you are trying to allude to is the cohort effect. So cohort effect is where there's a certain event they experience certain thing. For example, the cohort after, let's say, internet. Okay, internet is a huge event. People that are born after the age of the internet, they have very different characteristics than those who were born before the age of internet. You can see the characteristics. Yeah. So these are some of the things that is talking about the effect of certain things, characteristics shared. So this is more of a social thing. I believe Sancha is much better about cohort effect. What is cohort effect? So here it says it's a social science term that describes how shared experiences, for example, year of birth, exposure to radiation can cause variation in the group characteristics over time. So these are some of the things. Okay, but let's coming back to this. So these are the main stuff. The one in yellow are the one that I'll cover today. The rest are not so common, but you can read about it. Yeah. But we don't have to cover everything. I don't want to overwhelm you all also. So let's just cover 1, 2, 3, 4, 5 things. Okay, 5 things. First, let's start with cross-sectional studies. Okay, first thing, as mentioned, is a cross-section. So there is no temporality, okay? And of course, you cannot establish causality because if there's no temporality, you don't know which came first. Is it the lung cancer or is it smoking? Okay, so for this, you cannot establish causality, which is linked to the lecture 2 or weeks ago, which is on Hughes criteria. Okay, next is quick cross-effective hypothesis generation because you have one cross-section. Some people, for example, females have higher rates of certain cancer, for example, and then but I don't know which came first. Is it the female came first or is it the cancer came first? So then you can actually go and generate hypotheses to see whether is there any association. It measures prevalence. I mentioned the number of cases as well as certain potential association. Remember, there is no causality, it's potentially association. A snapshot. Okay. So often we do this type of studies, quick and easy. So these are some of the techniques we use. Prevalence ratio, we actually done that. Logistic regression. Certain things, certain outcome or certain issues, not the outcome, certain character, for example, diabetes. So we have a group of patients, we look at those with diabetes, they look at smoking, we look at diet, we look at exercise. Then we do a regression to see that for those with diabetes that was measured, they reported that they exercise less, they reported that they eat more. then we postulate that eating more and exercising less may lead to diabetes. But this is association, no causality. You want to do a proper study, you have to compare a group of patients without diabetes and then fold them up and see the characteristics. Some will eat more, some eat less. Some exercise more, some exercise less. And after 1 year, 5 years, 10 years, you compare the rate of diabetes among those that have higher exercise or low exercise and so on. That is actually how you can get the causality, or not really causality, that's how it's stronger, the association is stronger lah. Okay. Okay, next
So is
one.
this only retrospective?
This one can be prospective. I can do a cross-section study of the prevalence of diabetes in 2025 next year. So next year, I will just collect a random sample of population and then see whether they got diabetes or not. So they give me a prevalence study. Or I can find out those with diabetes, for example, in 2025, which is next year, and see what are their characteristics. Okay. Okay. Always good to have an example. This is an example. So this is a study by Dr. Nan Chuan, my boss in Pasir Ris Polyclinic. He's doing a lot of research work now. So you can see this. This is a cross-section study. I mean, how you know it's cross-section study? Usually look at the title. Because if you look at all the different stroke guidelines, right? They will say that it's good for your title to have the study design. Good practice. Okay. This stroke guideline is like a reporting guidelines. You can go and Google about it. Okay, next we go to methods. The methods, again, from the methods will tell you whether it's cross-sectional. So cross-sectional, cross-sectional. Okay, then you must be very careful. Always a lot of people will say A cause B. They talk about causation. So inside, you cannot use the word causation. Okay, so you can talk about association. Okay, the barriers to vaccination was uncertainty about long-term. So the key question is it because people are uncertain about long-term health risks, that's why they don't go for vaccination? Or is it that they don't go for vaccination, that's why they're concerned about the long-term health risk? We can't be sure which comes first. Okay? That's why there's no causality.
Risk of what?
Huh?
Long-term health risk of what?
Of the vaccine.
But
Yeah,
if
so
they don't take.
yeah.
Yeah.
I think this is the idea lah.
Yeah.
Okay.
It depends, but in this case, it depends on this is a survey, so it's survey questions. So the survey questions may intentionally be asking, like, why don't you want to get vaccinated?
Yeah.
And the answer is that I don't. I'm uncertain about all these things. Then this is the yeah, right.
Yeah, it can suggest causality lah, but then again, you're not sure whether it's because they don't go for vaccine. That's why because they don't go for vaccine, they what's the word called? They rationalize by saying, I'm not going for vaccine. Why I'm not going? Because I think it's not effective. So you're not sure whether is it because it's not effective, that's why they don't go for vaccine, or because the fact they don't go for vaccine, now they say that it's not effective. Yeah, some people like that one. It's very stubborn one. Once they don't do something, they rationalize. But that may not be a real reason why they didn't do it in the first place. Maybe they were afraid. But once they decided not to go for vaccine, they cannot back down and say they are wrong. Then now they rationalize and saying that the reason I'm not going for vaccine is because it's not effective. So no matter how much evidence you throw is effective, they will still say, I don't believe you. It's not effective. I'm not going for vaccine. Yeah. So these are some of the interesting behavioral people will know better. Yeah. So this is that's why it's not so straightforward. But anyway, the whole purpose is that it's in the title, it's in the study design, and usually they don't use the word causation, and then you look at how it's being done. So they use students, okay, so sampling, so they recruited students, okay. Then you see is there any follow-up data, no follow-up, only one time point. So one time point, so it's cross-section study. So three things: one, the title; two, the methods. And you read the methods, they only collect one time. There's no follow-up. So it is a cross-sectional study. Okay, very clear, cross-section study. Okay, good. Move on. Case control study. Okay, so first thing, usually is retrospective. Because these are rare cases. Okay, so you compare people with a rare cancer, maybe pancreatic cancer. The controls are the very important issue, because when you compare pancreatic cancer, right, you need to compare controls that could have pancreatic cancer. Okay, or you need to get controls that are very similar to the cases. Okay, if not, your results will be very different. That's why the selection of controls are the most important element for a case control study. The purpose is to identify risk factor for diseases, usually rare diseases. It's very efficient for studying rare disease and cost effective because you have the cases. You don't have to follow up 1,000, 10,000, 100,000 people to get one case of pancreatic cancer. Now you quickly just look at the pancreatic cancer cases, and then you compare with another group that doesn't have pancreatic cancer, which are very similar, and see what the risk factor. Otherwise, you have to follow them up for rare diseases. This is why we are often using this. But a lot of people think this is a bad design because it's very highly dependent on your selection of controls. So some of the things are recall bias because they're trying to recall history, so people forget. And then sometimes people who get lung cancer, then they ask them, do you smoke? I don't smoke. Are you sure? Oh yeah, I think I smoked last time. Then okay, maybe, or do you have secondary smoke? No. You sure or not? Your friend never smoked? Yeah, my friend smoked. That's why I got it. So a lot of time, all these recall bias because they think they got lung cancer and they think that lung cancer caused by smoking, so they rationalize and they try to have because it's very hard to remember. For example, do anyone remember what you ate last year? Last year today? Today is 18 November 20. Okay, don't ask. What were you doing on 18 November 2023? Unless you Google calendar, most people will not be able to remember. Yeah, so people may not be able to remember, you see. So this is called recall bias. How much people can recall? Yeah. So recall bias is very dependent on how you ask question. So you ask them question like, do you smoke or not? Then you say, no, don't smoke. You sure or not? Long time never try, man. Okay, maybe we have tried one or two. Cigar? All these things will start to cause all this doubt. Okay. Selection bias I mentioned is about the selection of the controls, because cases, cases are those with the disease. Controls can be anything, but preferably the controls should be people who are very similar to the cases. Okay. Extreme example, for example, you take breast cancer. Okay, let's say you take breast cancer and your controls are male. It'll be difficult, right? Because the rates are very different. So make sure your controls are selected that are similar to your cases. Okay, I think we covered this last time. We use odds ratio. Okay, because it's not directly a ratio. It's not directly a rate. It's more of a ratio. Okay, because you're copying odds, A over B, and they cannot sum them up because they don't belong to the same denominator. Okay, example. Okay, this is another study. I think I know some of them. This one is some guy from Ng Ting Fong, I think. Okay, so this is first thing, how do you know it's case control study? Okay, again, good a best practice according to stroke guidelines, have your study design in the title. Next, it's not very good the way they write abstract. Usually abstract is written as intro, methods, results, discussion. Okay, IMDA. Sorry?
Prospective.
Okay, prospective. Very funny, right? Usually it's retrospective, but this is prospective. Okay, never mind. But it's a case control study here. Case control study.
Prospective test negative.
What's this thing?
In this prospective means this study is a test negative case control. So they're looking for cases that are tested negative and versus against the control. So some of the women are with pertussis, some people doesn't have, right? So they're trying to look at the vaccine effectiveness. Okay. Yeah. So I think it's a study where they tested whether the women had the diphtheria, because pertussis is a vaccine that you take when you're young. So as time goes by, you may lose control. Lose effectiveness. Yeah. So that's why for pregnant women, they recommend to do a top-up. So 1 pregnancy, 1 vaccine. So 20 pregnancy, 20 vaccine. Yeah. So this is per vaccine. Okay.
Why the birth rate drop?
So only 25.9% of mothers receive this. So although it's recommended for it, only 25.9%, 1/4 of the women actually go for this vaccine. Okay. And worse still, only for 3.1% receive the vaccine. Supposed to be child. I think it's a child vaccine. Pertussis, which country is that? Singapore?
I don't think
So 3.
Singapore.
Yeah, but why so low?
Yeah. I expect it to be 100.
Okay, so it's interesting study. You can read about it. Yeah, I thought that it's compulsory. Maybe it's taken. I think you look at how booklet is taken in the first year. Okay.
First year.
Yeah. Okay, never mind. This is the details already. Okay, but this is a case control study because number 1, you have the title, the study design, and the design can see that the cases are those.
That's negative.
Yeah, test negative are the case. Then control are patients who are not test negative. Okay, so that's the way they compare.
Wait, control is not.
Yeah. So what cases are the one that you're interested in? The controls are someone who is very similar that you put inside to compare.
But that's positive.
Okay, so in this case, the cases will be those with maternal vaccination Then your controls will be those without maternal vaccination. Okay, so that is the study design. Okay. Next is cohort study. So usually it's a follow-up. They have follow-up studies to see whether the exposure leads to outcome. There are two types. It can be prospective. Prospective means you follow them up. Retrospective means historical. Go back. So prospective forward-looking, retrospective backward-looking. Okay, it can establish temporality. Again, be careful. It's not causality. Remember the Hughes criteria? Okay, I can establish temporality means I know that A is before B. For example, I know that people smoke, then get lung cancer. I cannot prove that smoking caused lung cancer. All I can show you is that the lung cancer came after the smoking. That's why you only establish temporality. Okay, no causality. Okay, very important. Okay, causality you need to establish a lot of other things. Expensive, okay, especially for prospective to fold them up. And what the women study? So the Singapore study, there's a Singapore women study. Until now, I think it's called Wen Hui, still folded up. She inherited this cohort from this, I don't know, die already or not. It's called Mimi Yu. It's a US person. So she inherited this cohort from this. So this is a few type of research, right? If you do it, right, your cohort may outlast you.
One study, one cohort, one career.
Yeah, your means that you may retire. Okay, don't say you die. You retire and you pass the cohort to somebody else younger to take over.
This
Okay.
is not a Chinese cohort study.
This one next study as well. Is it? No. Yeah, it is. This, okay, next study. Okay, wait. Okay, so anyway, this is the type of study law. So this is called a cohort study. Okay. So you have a lot of interesting things because every few years, maybe 5 years, you'll recruit them back, and some will die, some will migrate, blah blah blah. Then you can get more data. So it's very interesting. And then the historical data was collected maybe at the start of the study. And then 5 years later, 10 years later, some get cancer, some get heart disease. Then you correlate with what you collected earlier. This is called a cohort study. Okay, the prospective cohort study. So I think we covered this relative risk, hazard ratio. Okay, I think that was previously. Hazard ratio is more for survival analysis. When you look at the time to event. Okay, I think this one we don't really cover, but never mind. If I got the opportunity, I'll cover that. Okay. Okay, so yeah, so this is roughly what it is. Now I'll talk about example. Okay, I too lazy to write this. But how do you know this is a cohort study? Very simple, always look at the title. So, okay. So in the past, reporting was rubbish. Okay. Now with these stroke guidelines, right? The first thing as a reviewer, I'll say, please follow the stroke guidelines. So once you follow, right, you need to put the study design in the title. So nowadays you get better and better title because it has a design there. Okay. Not just cohort study. What sort of cohort study? Prospective cohort study. Okay. Okay, so this one I think is the Singapore Chinese study. You see, it's collected from 1993, 1998. So more years, right? This study is in 2022. So after 20, 30 years, they can redo the study, just look at the outcomes and compare with the data they received at the start. Okay. How else you know it's a cohort study? You see that the data was collected in 1993 and 1998, right? And then these are all baseline, this is called baseline. And then the new cases, the endometrial cancer was identified in 2010. So there are 2 time points. One was the baseline, one was the 2010, which is the outcome. So that's why it's called cohort study. Okay. Here they use this design called cost proportional hazard model. If you're interested, you can ask Cheryl, biostatistician. So this one look at the time to event. Okay, time to event study. Okay, you all can learn about that. Usually that's a bit better because when you have time to event, you account for censoring, you account for a lot of other things. That's why this style design is a bit better than just logistic regression. Maybe ask Ernest and Matthias, have you all learned survival analysis, time to event analysis? Failure analysis, no, very common in engineering, right? Time to failure. You never learned before. Time to failure analysis.
And your survival will be time to event.
It's 2:30, so sorry. You can finish. I will send you the slide, don't worry. Yeah. So anyway, that is the time to event type of analysis. Okay. So if you're interested, I can read more about it. Maybe I'll cover this one day. But yeah, but here just focus, this is a prospective for hot study. So I think some of these things we remember, person years. So it's the number of person multiplied by the number of years of follow-up. I hope you all remember. You look at the number of person, let's say everyone follow up for 10 years, then it's 100,000, maybe 10,000 person for 10 years. But some people are follow-up for 5 years, they get a cancer. Some people follow-up for 5 years, they die or they lost a follow-up. So that's why you use person years. You don't just look at number of person. You look at number of person times the years of follow-up. Okay, so everything, see, all these things what I teach, right, is all really relevant. Because you can find this in all these research studies, so you can understand better. Okay, this one is one of the largest cohort studies, but to do this sort of study, somebody must have invested in 1993 to 1998, 34,000. Somebody must have done this. So there's no way you can go back, do this study now because you need to start somewhere. So all these studies are really very, 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 very precious. Yeah. Okay. Move on. Okay, this is another one. This is a retrospective cohort study. Okay, this one is looking backwards. This one is from Stephanie Cole. Not sure you remember her. She's a mobile inpatient care. So basically, first thing, how you know this is a retrospective study is written here. Retrospective. Sorry, how you know this is a cohort study? It's a cohort study here. What sort of cohort study? Retrospective. Not just that, it's descriptive. So it's not analytical. They will tell you it's descriptive. I just describe, I never analyze. Actually, they say analyze, but never mind. It's a single center, very important. So it's one center, which is NUHS or Alexandra Hospital. I think it's Alexandra Hospital. Okay. So these are the things you follow up: design, setting, participant. Again, 20 months. So there's a period, it's 20 months. So primary measure are those that are hospitalized. Okay. Secondary measures is a utilization pattern. Okay, not sure what is it a cohort study. They only look at this.
Can you open up again? So bigger cannot see.
Cannot make it bigger. You can come closer. You can do bigger. Go bigger. Okay. Oh, you can make it bigger. Not bad. Okay. Anyway, this is the example lah. Okay, so this is HAH. I think it's hospitalization at home. Okay. So yeah, cohort. Sorry.
Yeah, why is this? This is just a look back of a cohort. When they say cohort,
You may have misused it lah. I think so, but never mind. Anyway, it's a cohort. So cohort, a group of patients lah. Yeah. Okay, never mind lah. I mean, it's still published. Okay, so let's move on. There's a button. See, now you spoil the thing. Okay, randomized control trial. This is important randomization. So by chance, some are in the intervention group, some are in the control group. Very important because randomization will help to adjust for the back factors. Because if you don't randomize, there may be some selection bias. So by randomization, hopefully if it's done well, the characteristics will be very similar between the two groups. But there are two things you need to do. Number one, the size must be big. If you have a small number, let's say you only got 3%, okay, 2 girls, 1 guy. No matter how you randomize, it's only 2 girls, 1 guy, or 1 guy, 1 girl. Yeah, you know, there's not much you can do lah. So you need to have a big number, then the characteristics can be distributed equally, okay? Or at least you try to do it, because by chance, sometimes after randomization, the patients are still different, but you already tried, okay? So why can't you match? Why can't you use matching or stratifying? Matching means you want to, let's say for diabetes, you want to have equal number of diabetes in both groups. Why can't we do matching? Anyone want to guess? Actually, the answer very simple. You only match for things you know. Let's say diabetes, you can match, right? Then asthma, you can match. But for characteristics you don't know, there's no way you can match. And there's so many characteristics you cannot match. I want this cohort to have 5 diabetes, 3 asthma, 2 heart disease. Can be so precise. So the way to do it is to use randomization to help us do this. Both to correct for those that are not measured and for those that they are measured, but then we were unable to allocate efficiently. So that's why we randomize. So by randomizing, we hope to control for confounders. Confounders are factors that are in a pathway. They may affect our interpretation. So we'll discuss more about confounding. Okay. Then this will help us to establish, hopefully, causality. The strength is high validity, and then the bias is reduced because we don't have selection bias because it's randomly selected. Okay. Problem, I think Ernest mentioned ethical concern. So you have 2 patients. One is very in need of the treatment. If you don't have the treatment, he'll die. The other one, still early stage, if without the treatment can still survive. And you do a randomization. The one who needs the treatment is randomized to the control group. This is true, no? So some people, some study cannot randomize. If randomize, is not fair, okay? And some people actually, you go read about it, some of the cancer trials, right? The patients pay money to be in the treatment arm. They actually pay money to be in treatment arm because their cancer is cannot be cured. There's a new drug, may or may not work, don't know, but got chance. So some people will bribe themselves to get into the intervention group. Yeah, because if you got intervention, there's a chance to survive. If you go to control group, you're given placebo, no chance. Okay, so a lot of ethics involved. And of course, it's costly, not cheap. You need double the number, remember? Because half of the population, you're going to randomize them to placebo, which is no treatment, or standard care. Okay? And when you do this thing, you need to pay for everything involved in the study. So all the blood tests need to pay, all the monitoring. If something happened to them, you have to pay also. So this is covered by the trial insurance. Okay? So the methods, there are two types of methods. One is called intention to treat. One is as protocol. Want to guess what the two means? What is intention to treat and what is as protocol?
Intention to treat is the treatment. Protocol is just the gold standard.
Okay, not quite. So intention to treat, very simply, let's say I put you two in a group. I give you this medicine. Okay, I give you another placebo. Then you don't want to take this medicine. You take some other things or you don't even take at all. When I do analysis, right, I will do it as though you took the medicine. So the bar is very, very high. So if you don't take the medicine, I will still take your outcome inside my analysis. This is called intention to treat. Okay. As protocol means I'm allowed to exclude you because you never take the medicine. So obviously your outcome will be bad, ma. So I exclude. I only take those who follow the protocol, who came for follow-up, everything sweet. Then I'll do the analysis. The intention to treat is a way to simulate the real environment. If I give you a drug and no one takes the drug, by intention to treat, I still have to take those who don't take the drug into consideration because in real life, this is the real effect. Because I give you a drug, you don't take it. That's called intention to treat. As protocol analysis is more is actually more biased because it only take into consideration those who follow the protocol and I look at the analysis. You want to look at the two type of result, usually intention to treat is usually used because it's actually more real life. Okay, survival analysis I think we covered just now. Is another term called, it's called time to events analysis. Survival is just when the event is death. Okay, I think you cannot see. So how do I make it bigger?
Control plus.
Control plus. Okay, so this study, okay, by Yoshika, okay, a smartphone app to improve medication adherence in patients with type 2 diabetes in Asia. Okay, first thing, how do you know it's randomized control trial? The title, go to the methods, we block randomize. Okay, later these are the different ways to, block randomize, if I'm not wrong, is you randomize by group. So maybe 5 at a time. Or Monday, this group is randomized to the treatment. Tuesday, randomized not the treatment. Wednesday, it's not as good as individual randomization, but it's in blocks. Okay. So usual care plus MediSafe app. You spell correctly or not? Okay, never mind. Not my problem. Okay. Anyway, yeah. So this is the study. So Yoshika, very, very established. Even he also got correction one. Okay, so journals are not 100%. You may still make errors, and then you have to write this stupid thing to say that it is erratum.
Feasibility randomized control trial.
I think this study, the sample size may be small. It's only 51. This is why is to see whether is it feasible. It is not meant to test for efficacy. So feasibility means can I do the trial? Then with the results, then I use the money, the result to get more money to the actual study.
Proof of concept.
Correct. Proof of concept, feasibility. Okay, because if you're not established, nobody will give you money to run a proper actual trial because the trial is so expensive. You need to have the track record. So when you go for any grant, they ask you what is your track record. No track record, nothing, cannot do. So that's why even him, he has to do this feasibility trial to get money to do this. Only 51. So 51 straight away, if you use any sample size calculation, it's not powered to detect a difference. It's just to show whether is it possible to do this. Okay, the key thing is it acceptable? They never see whether is it effective. It's only whether it's acceptable, whether people do it or not. Okay? Yeah. Okay. So this is called a randomized control
The
trial.
conclusion?
Huh?
What's the conclusion of this trial?
It's feasible.
It's feasible. Can get money to pay.
Yes.
I think it left already. Conclusion is this shows that those with poor compliance with type 2 diabetes, you can use a smartphone app. They will use it, like it's acceptable for them to use it. Okay. So this is
But
all
did not
that.
improve clinical outcomes.
Yeah. There is also improved awareness, but the clinical outcomes, okay, there are two reasons why it didn't improve. One is really never improved. Two, it improved, but because it's not powered to detect the improvement, therefore it didn't show as statistically significant. Okay, so I think another thing you must remember is when you do research, right, when something is positive or negative, there are two interpretations. One is it's really effective. Sorry, the other way around. It's really not effective, or because your sample size is too small, you couldn't detect the effectiveness. That's why you need to have a rather reasonable sample size. But this is in an era of small data. Now it's the other way around. Now it's a large data. You have 1 million people. Okay, so it's the other way around. This you can have spurious correlation. So now you need to take this thing called the Bonifery correction. You need to take a stricter. So instead of 0.05 as a cutoff, you may want to take 0.001 as a cutoff. So anything that is weak, throw away. You only want very strong association. Otherwise, by chance you test 1,000 things, you can get some that are positive, but may not be very significant clinically. Okay, good question. Okay, let's move on. Okay, quasi-experiment. These are intervention studies without randomization. It's still experimental, but we don't really randomize because sometimes it's difficult to randomize. Sometimes patients don't want to randomize. Sometimes our stakeholder don't ask us to randomize. So you can do some sort of design, like for example, in stages. How come polyclinic do the thing? Okay, so this is the case. After that, Clementi is the control. Then 1 year later, Clementi do the thing, and then another polyclinic is control. Okay, because you cannot randomize. Ideally, randomize Geylang Polyclinic. Half will be in the intervention, half will not be in the intervention. But I think about it, if you're running in the polyclinic, it is operationally difficult to run two groups. So every time you need to check your which group, or you're this group, you'll do this. You're this group, you'll do this. Okay, it's difficult, you get schizophrenic. Okay, and also it's not nice because let's say this group got a smartwatch. Okay, then another group can't see, where's my smartwatch? Oh, you're in the other group. No smartwatch. Okay, so sometimes they do it by polyclinic. So one polyclinic got smartwatch, the other polyclinic usual care no smartwatch. They cannot compare. But if in the same polyclinic, people start comparing, how come you got smartwatch, got Apple phone, all these things, see? So all these things will cause issues, with the PR. That's why sometimes good to have randomized control, but may not be possible. So most of our studies are usually not randomized control. Very hard to get randomized control, although randomized control is the highest evidence. So it's useful when it's not practical to have randomized control for whatever reason. Sometimes they don't want it. Someone is hard to recruit. And the problem is that there's not confounding because it's not randomly decided. So there could be selection bias. So you can use regression model, or you just mentioned time series or interrupted time series. Okay, this sort of analysis to do it. Okay, and this is the real world evidence. I mean, real world setting where you can assess intervention without randomization. Okay, so this is an example. How do you know this is a quasi-experimental study? Okay, you can realize that every time it's all in the title. Go to the design, this quasi-experimental study. Okay, so the type study. So this is very easy. So how to recognize study design? Very easy. It's all written there. Okay, so one ward assigned to intervention or control group. Okay, make it easier. So it's by ward level, not individual. Make it easier, like one ward, half need to do something, half cannot do something. Then there'll be contamination also. Because if let's say one ward you read stories to half the patient, the other half of patient don't read the story, the other half may come and listen in. Then there'll be dilution. This is called contamination. That's why we want to do it at a ward level. Okay.
Does it matter if the wards don't have the same size?
May or may not matter. Here is 74 nursing home residents, is 37 each group. So by chance, the ward size is the same, 37. Okay, good point. But so this goes back to the efficiency. If I'm not wrong, the most efficient is equal number. For controls, it's 2 times or 3 times the number. Something like that. There's something about the efficiency of the trial. Okay, but it's good to have same number. Okay, right, wrong.
No, I'm asking.
Efficiency, you
I'm
can
going to
ask.
ask question.
Okay, go ask, go ask.
So here we have wards to be so-called allocated, assuming there are 200 wards in this nursing home. And then if we say that, okay, randomly we choose whatever number of wards, that could cause it to be a RCT or
No,
still
it's not,
quality?
still not RCT.
Why?
Because you're randomizing at the ward level.
Yeah, but
Because
randomizing at ward level and randomizing at the person level may not.
this is
Too
there will
much.
be a cluster randomized trial. Okay, that's called a cluster. Okay, but randomization is at the cluster level or at the ward level.
Okay.
Potentially possible to call that. Okay.
So are we in a way lowering the expectation of this by calling it quasi because there are too few wards and we can't guarantee that the wards that have been assigned are not totally the same. So one ward could be younger, one ward could be whatever. So therefore they are kind of managing the expectations lah.
I don't have the data, I don't have details, but I can go and Google what is a cluster randomization. I don't think you can randomize one ward versus another ward. Maybe a customized, maybe you need 20 wards, then 10 or 20 wards, 10 of the wards is this, 10 of the wards the other.
That's why
that could be the definition of a cluster randomized trial lah.
Sure.
Yeah, otherwise it becomes very funny.
Because in life they'll say that if my ward and your ward are slightly different, level 3 or level 2, I'm nearer to the toilet, therefore I'll be better, things like that lah. So they kind of qualify themselves lah.
Okay, so the example they gave was 20 schools. So if it's 2 wards, I don't think you can do a cluster randomization.
Yeah.
But very good to ask someone who is expert, maybe Joey lah. Okay, anyway, back to this. The most important slide is here. Okay, it summarizes all the 5 I mentioned today. Cross-sectional, so just remember, what is it? Is it observational or experimental? So these 3 are observational. You have no intervention. You're not touching the patient. That's why ethically, you only see eye power. Okay? These 2 need to have a lot of ethics because you're doing something. Either you're doing something or you're withholding something. Okay? Especially for this one, because the ethics are important. Okay? Is it a dying person? Is it ethical giving the placebo? Yes, no, question mark. Okay? This one is non-random. Okay, less, but still. Okay, timing, this is 1 point, only 1 point. Case control, usually retrospective, I don't know why it's called prospective, usually retrospective because looking back. Cohort can be prospective or retrospective. RCT usually is prospective. You cannot randomize in the past. Yeah, there's no way you can randomize the past, so it's a prospective study. So in general, prospective study, I think the evidence is stronger because there's less recall bias. Key features, you can measure prevalence, compare case and control, and then you can follow up a group, this follow-up to see who get the outcome, randomize one or the other, and then this is similar but doesn't have the randomization. Advantages, very simply, this is the most expensive, it's called the gold standard. High internal validity, you can potentially establish causation because you use randomization to remove the confounders. Quasi, not so good, easy to implement. And these 3 are generally quite cheap and to do lah. Cohort study, you need to follow up for many years. That's why it's very expensive. Okay. And then case control study is good for rare diseases. And usually cross-section study is the one that often used lah. Okay, just do a cross-section. You look at the National Health Survey, it's all cross-section study. But sometimes they re-invite the participant for follow-up study. Okay, then it becomes a cohort study. So you can potentially convert a cross-section study. You keep the data, and then 5 years later, 10 years later, contact them again. Then your cross-section study becomes a cohort study. Yeah, potentially. But you need to change your IRB. So causation I covered last week or 2 weeks ago. Remember, no causation. This one, nothing about causation. No causation also. No causation. So only this one probably be causation. The only problem is the ethics. And it may not be generalizable because your randomized control trial is so nice. You choose people who accept. You choose people who are willing to be randomized. Remember, people who are willing to randomize are different from most people. Yeah, for you, if you go for a trial, do you want to randomize? You can have this new drug or you can have sugar pill. Okay? Very dangerous, no? The new drug may be poisonous. You don't know, no? Yeah, it's a lot of high risk. Yeah, or unknown. Yeah. So these are some of the things you can consider. Okay, so this one I'll send the slides. Okay, so remember this.
So like my questions earlier, I mean, I think I also remember Prof. Dick and whoever also shared some of the more funny design, right? Like you talk about like the even on time series. So sometimes they say that okay, there are two cohorts. So one cohort do this first, one cohort hold on. Then after a while, then you switch. I don't know what you call that, switch over design and some of this funny design it come out lah, to, I don't know, to kind of, I suppose, to give more weights on the causality despite not able to RCT.
You're talking about the regression continuity, discontinuity
Some of
design,
this
is it?
then they
Yeah.
do a switch over, whatever lah. So there are some kind of a more funny design that they may have.
We learn the basics first.
These are the basics.
Once you learn the basics, then you can read the details. There are nested case control study. So in a cohort, you can nest it and look at the cases and control. It's called a nested case control study. So there are more difficult terms, but for now we do basic ones. So these are basic ones.
But for the data
So
science people, most of the time we don't even do all this study lah. We just do what we call that, retrospective case matching.
case control, or you do a
Matching
cohort
lah,
law. A lot of
matching.
time you do cohort law, like the
Yeah.
cohort of asthma patient, for example. Then you look at a cohort asthma patients, some have some die, some don't die. What's the reason?
Which
Yeah.
sometimes is interested, right? Based on the longitudinal data that we have. He was talking about cohort studies. Because we track sufficiently long enough, 20 years or so, we are able to do that.
Our population is like a cohort lah, the cohort of NHG
Not really long,
patient.
16, maybe 16 years that we have.
Yeah. Okay, so back to this. So key takeaway, observational studies, okay, the cross-sectional case control cohort, they are better suited for generating hypothesis, identify association, not all, cross-sectional cannot identify association. Actually, they could lah, sorry, can. And then studying risk factors, okay, risk factors. Experimental studies are more for determining causality and evaluating the effectiveness of intervention. All has the strength and limitation depending on what you're doing. So as what KL said, your focus mainly on probably observation study. I don't think any of you will do experimental study unless you're in the evaluation team. But even then, they don't do it. They just evaluate the design. Yeah. Okay. And then these are some of the things to consider lah. Any questions before we end? I will off the video now. I hope I recorded it.